Hi, everyone. I'm Dr. April Jasper, and I'm Chief Optometric Editor of Optometric Management Magazine. And it is an exciting day for me because I get to be here with one of my really good friends, Dr. Mile Brujic. And for those of you who don't know, he is practicing in Ohio. The name of his practices is Premier Vision Group. But honestly, I want him to tell us a little bit more about himself. So, Dr. Brujic, welcome.
Thanks, April. Thanks for having me. Yeah, just to give a little bit of a background, graduated in 2002, and for the past 19 and a half years, have been in Northwest Ohio. We're now a partner, or I'm a partner of a 4-location optometric practice
Oh,
here.
wow.
Yeah. So we've been busy, and we've always been of the philosophy of incorporating new technologies, and not only technologies that are flashy, but we want technologies that are going to kind of help us manage and steer better patient care. So that's always been our philosophy.
That is what I know you for. I mean, I think what makes you unique, Mile, is that you not only know about what's new and advanced, but you always are good at helping us to know how to really make it happen in our practice. So today we're here with Avellino. We're talking about, what are we talking about, Mile?
Genetic testing for keratoconus,
I
AvaGen in
love it.
particular.
Yeah, and you
Yeah.
know what's interesting is there have been so many people who have told me that they're very interested in this conversation and they're very interested in AvaGen, but they don't really understand how to bring it to life. So we're going to do that today. So before we go any further, though, I want to encourage all of you, please tell us who you are, your practice name, and jump in so we can get your questions, and we promise we'll be able to answer those as we go through the program. So as we get started, let's start, Mile, with you telling us all a little bit about AvaGen and just how it works.
Yep. So one of the things, whenever we discuss genetics, it starts to become a little bit of a murky area because we're not familiar with that in eye care. So to take a step back, why this is important, April, you get patients asking questions all the time, like, why did I develop condition XYZ, regardless of what it might be? And my kind of response always to these patients is any condition that you develop is a combination of two things. One, it's the genetic risk that you carry, and the second is the environmental risk. Now, most of the time with most situations, we can't really do anything about the genetic risk because we don't know what genetic risk that individual might have. But we can modify the environment to reduce the modifiable risk that we have. Well, with keratoconus now, we actually have a little bit of a different pathway, where we used to say, we don't know your genetic makeup. We don't understand what your genetic risk is. We now understand that genetic risk. And essentially what it is, April, it's a cheek swab. We do it right in the office, and then we send it off to the lab. They analyze the data. So what makes keratoconus unique is that it's a polygenomic condition. So it's affected by several genes. And the more of these gene mutations you have, the more risk factors you have. The cool part about the printouts is when they send it back to you, they really kind of demystify a lot of it so that they put the individual in a category of either low risk, moderate genetic risk, or high genetic risk. And based on that, you can kind of make better decisions on how you're going to be managing that patient.
Wow, that is powerful. So how did you get involved with this? And really, what prompted you to start using AvaGen in your practice?
Yep. So whenever I see a new technology, I always look and ask myself, is there a void, or where would I use this type of information? And the low-hanging fruit were those individuals in my practice that, you see some level of corneal steepening on topography, but it's not necessarily clear or frank keratoconus. You
Right.
see some off-centered thinning on anterior segment pachymetry scans on the OCT, but it's not a frank keratoconus. You see individuals who are keratoconic patients who have children, and they want to know, what's my child's risk and what should I or shouldn't I be doing for my children? And you start realizing there's this kind of void, this place where you think, and I really would like to have more information on these patients. April, one of the things that we've kind of done too, like recently in particular with myopia management and progressive or developing, or excuse me, controlling the progression of myopia, in particular with orthokeratology, we realized that we're doing much more scans on patients. And because of that, we're starting to see these kind of peculiar, particularly what I would call challenging to interpret topographies come up. And at times before we treat, we do want to know what that genetic risk is. And certainly for those patients, that we're considering refractive correction for, specifically any type of surgical options, we want to make sure that we're dealing with an individual if there are suspicious findings on any of the topographies, anterior segment OCTs, tomographies, whether or not we're dealing with a low genetic risk, a moderate or a high genetic risk. It just helps us guide that patient's future better from that point.
Yeah, that makes a lot of sense. And I think that many of us have seen information about AvaGen, but I think that the challenge always is with this and with many things is how do you actually implement this in practice? So let's jump right into that. Tell us how you have implemented this in your practice so that more of us can really do the same.
Yep. Well, so here's the low-hanging fruit, April, and then here's kind of how we've evolved this process as we've understood more about the technology. So initially, it's a conversation with patients who are keratoconus and who have children and are wondering, is my child destined to have my future? So they always want to know. So those are the individuals that kind of you think of immediately and say, okay, we want to know what their genetic risk is, because we take them on two different paths, even from a follow-up perspective and also to how we manage things. Like oftentimes these kids that have high genetic risk have allergic disease. So we're managing them much more aggressively just to keep the hands away from the eyes. If they come back with high genetic risk, we're seeing them on a higher frequency. Typically we see kids that are healthy, myopes that are progressing, assuming that we're not doing anything special with them other than correcting them with glasses. We see them back on a yearly basis. If their prescription changes, we see them back sooner. We may see these kids more frequently, and we may take more measurements on their corneas if they come back with a moderate or high risk, because we know that the treatments that we have right now are so much better, especially with corneal cross-linking. Where we've kind of evolved this a little bit is over time, we've now kind of started to look at everybody a little bit differently. I look at the patients who have the oblique or against the rule sill that are progressing or increasing in amount, those individuals that are those patients that are progressive myopes that have against the rule or oblique stigmatism, those individuals that you're taking the, again, topographies and there's question marks around them and they're progressing. These are patients that, again, they're in this bucket of like, you're kind of monitoring them, but you don't necessarily know how frequently or infrequently too. And you're kind of giving them these recommendations on not rubbing the eyes and things like that. So number one is identifying appropriate patients. And I've given a few details there. But the second thing is really understanding the process of collection of the sample and also sending it. That's where you really leverage your technicians substantially. AvaGen has done a nice job of setting up a system for the practitioner so that they can train our technicians on how to appropriately do these tests so that we're not necessarily involved in it. So just to give you perspective on exactly the process, identification occurs in the exam room. So during the regular exam, I talk to the patient about it, and assuming they want to know that genetic information, we find that most people do. There are some individuals that just prefer not to, and I respect and understand that as well. But we always have a conversation, and there has to be a mutual agreement on, yep, this is the next best step moving forward. I message my technician to come back. They come back with the AvaGen test. They collect the sample. I go see other patients, and then usually when I get a break, I go back to my desk. The form's back there. The technician is already pre-populated with everything that they need to. I just sign off and say the diagnosis that we're checking for, and then the technician sends it off to Avellino, where it gets analyzed. And then what you'll receive is an email about 10 days to 2 weeks later that says test results are ready to view. And then you open it up in your email, you print it out or download it into your EHR, whatever your process is, and it shares with you exactly what that patient's genetic risk of not only keratoconus, but interestingly too, corneal dystrophies as well, which we don't talk about a lot, but there's even a role there as well. And then we call the patient to give them the guidance on what we're doing. And just to give you perspective too, so we have a few ortho-K patients who came up with some peculiar topography scans. So we already had them scheduled back in 2 to 2.5 weeks. And we're going to talk about the results with them then and determine whether or not to proceed or if another path is best for them. And sometimes we'll just call them back, April, and discuss the results with them.
And you probably can tell based on your first conversation with them, if they're going to be one you need to have back in the office or if a phone call is going to be okay, right?
You are so spot on. That's where the art of practicing comes in, and it's this thing we joke about practice, and that people want to go to the experts. Well, I would personally rather go to that individual that continues practicing and wants to get better and better and better. And that's what we're doing. And April, you're right. You kind of identify those individuals just from the history with the office and how well or poorly they come in for follow-up visits. But yeah, 100% correct.
So it really then sounds like it boils down to some very critical benefits that you see from using AvaGen. What would you say those are?
A few things. One, in particular, with children that are progressive myopes. One, we want to identify these individuals early because from an insurance perspective, you have to show a certain amount of progression before they even qualify for corneal cross-linking. And we also understand that the earlier they get cross-linked, the better the outcomes are. I personally think, April, we're in an era where we can potentially, assuming that we can incorporate this appropriately as a profession, we can potentially get rid of penetrating keratoplasty for severe or advanced keratoconus. This could be a thing of the past where we're talking about and say, yeah, remember when we used to do corneal transplants for keratoconus patients? Remember when we couldn't do anything for these individuals? So there's just a lot of benefits that earlier identification, removing or reducing environmental stimuli to disease progression, and also providing them treatments earlier, it all just benefits the patient so tremendously, not only today or tomorrow, but in a decade, 2 decades, 3 decades from now as well.
Absolutely. Wow, this is incredible. So let's go a little bit different direction, Mile. I want you to, based on your current experience,
Yeah.
what recommendations operationally? Because again, I'm worried that people will hear this, think it's awesome, but also think it sounds too complicated. So what recommendations do you have and best practices really that you would suggest for implementation going forward?
Great question, April. I'll share with you a few things that we did that I think made it as successful as it can be. First is from a clinical perspective, you really have to determine what are the patients that would be most valuable to have this information on. And again, it's the individuals that are in this kind of questionable bucket, patients of parents who have keratoconus that want to know what their genetic risk is, or these individuals that you're going to be doing some level of manipulation of the cornea, whether it be surgical or orthokeratology, where you want to know more genetic information on it. So clinically, you have to understand kind of what bucket of patients is this going to apply to. The second thing is you need to understand what the results actually are and what they mean. So spending some time with your AvaGen rep is important. And the third, and arguably the most important thing, April, is making sure that your technicians are fluent on sample collection and sample sending. Now, the cool part about this is that I've actually watched my technicians do it. It doesn't seem very laborious, but they know exactly what they need to do.
Right.
So I think they're making it look very, very easy, but your AvaGen representative can actually walk you through this process and more importantly, the technician that's going to be performing the test through that process. So they know exactly what to do. So three big buckets. First thing is, from a clinical perspective, what patients are you going to feel like you would gather the most information on this and have something that's clinically usable to change their course. The second thing is making sure that you understand the test and think about how you're going to explain it to patients. And then the third thing is making sure that your technicians are fluent in the way that they're collecting the sample and sending it off, and how you're going to review that data and everything.
I love it. We looked at the video. I saw the video online that shows the sample collection process. It's very well done, and it does look, like you said, like something our techs could easily handle.
Yeah.
So in the last few seconds or last couple of minutes that we have, I would love for you to share with us some patient scenarios. So tell us about some real people that you worked with.
I'll tell you about the first two patients that I ran on the test. It was my oldest daughter, who's 13 years old, and my youngest daughter, who was 10 years old.
Oh, wow.
They came in for eye exams, and they're both progressing myopes. And on my youngest daughter, I actually wanted to start orthokeratology in April. Both of them have remarkably thin corneas. My oldest daughter was 460. My youngest daughter is 430. So
Wow.
again, just seeing those corneal thicknesses is suspicious to me. We don't have any family history of keratoconus, but before I wanted to place an orthokeratology lens, which my wife and I, we talked about it, before I wanted to put that on the eye, I wanted to make sure that it was a safe place to place it. And the great part is when we actually, we ran the genetic test, there's a low genetic risk. So it immediately gives me a sense of security moving forward with them, where I don't even have to think about any type of safety precautions that I maybe have to take with either of them.
Wow. Now that's a story that's really true. And
Yeah.
you feel it as much as a parent as you do a doctor.
Yeah.
That's incredible, Mile. So a couple of questions have come through, and this is
Sure.
actually one that I've heard from people as well. And that is, where do you see the advantages and value of AvaGen to the community, meaning the rest of our doctors that are listening, our colleagues today, and especially for those who don't necessarily have equipment that you've mentioned, such as topography and tomography?
So interestingly, oftentimes you hear about these technologies utilized and coupled with these other advanced technologies. Where I think it even has a greater role, April, is for practices that may not have the technologies. For example, somebody who doesn't have a topographer or an OCT, so they don't have that data to look at, and they're seeing
Right.
an individual who's progressing or increasing oblique astigmatism with increasing myopia, best corrected visual acuities may be just slightly lower than 20/20, or they might be a soft 20/20. This is now an extra piece of diagnostic equipment that doesn't necessarily cost the practice significant dollars to incorporate, meaning you pay as you go. So you pay for the test as you order the test. So there's not any type of cash outlay for this additional information. So it may be, although again, we like to pride ourselves on having technologies and all of these measurements, it may be even better suited for the practices who don't necessarily carry some of the higher diagnostic technologies.
Absolutely. So tell me, I have to think back to when you told us about your daughters. That sounded like it was very emotional for you, as well as, if you step back as a doctor, it's very important professionally for you. But now I wonder, what are your patients' reactions? I mean, when you tell parents or you tell a patient that this is something that's available and that you recommend that they go through, what are they thinking? What do they ask? What are the reactions? And then how do you address that?
Well, so I'm pretty direct with patients, April, and I share information with them the way that I want to be shared information as a patient as well too. So think of the last time you go to a physician. You want the physicians, you want them to give you the choices, you want the physician's recommendations, and you want to know why the physician's recommending this. It's the exact same way that I give the information to my patients. So I asked them, I said, have you ever heard of keratoconus? And then we all kind of have our little spiel on it. So I give my little spiel on what keratoconus is, and I share with them, let's say, for example, it's the patient has the suspicious topography or the suspicious pachymetry or advancing oblique astigmatism. So we share with them the reasons why we're suspicious of it. And we share with them the fact that everything that develops is a combination of genetics versus environment. We know that you have some environmental risks. Some of the diagnostic tests I'm seeing show some risk factors, but it would be so much more powerful if we had this genetic test, because if we have this information, we'll know how to better manage you. Patients always say, well, what do you mean better management? I tell them a few
Right.
things. One, if it's low risk, we can back off and we don't need to monitor you quite as frequently. If it's a moderate or high risk, we become much more aggressive at managing the allergic eye disease that you have. What we also do too is we see you back more frequently just to make sure that we're detecting any type of subtle changes, because if you need treatment, there are advanced technologies that we have available. And I'll tell you too, April, this is just another anecdote. We have tons of data on scleral lenses over the last 10 to 15 years. We cut our teeth with some of the early designs. And what we found is that these individuals who have keratoconus, they progress less rapidly under a scleral lens than they do in traditional soft and GP lenses. And I think it's just a lack of access to the cornea that's causing that. So there's a bunch of different paths based on the patient's needs.
So is there, for the person, I think there might be another concern that doctors have, and that is that what if you mentioned that we need to understand the results. What if they're concerned that they may not know how to really talk about that? Is there anything out there? Does Avellino have
Yeah.
anything that will help them?
I think that's one of the benefits. I think they're really supporters in this process. They've really kind of dug their teeth into this whole thing, keratoconus early diagnosis. And
Incredible.
one thing that they have done is provided a tremendous amount of support, not only to practitioners, but also to patients. So there are services that are available for, one, the practitioner, help me understand this better, not only on their website, but with phone consultations. And the second, and even more valuable thing is phone consultations for patients as well too. So
Oh,
there's
wow.
there's this suite of tools that's available so that you're not left on this island kind of questioning all of these things and wondering, well, what am I even going to do with the information? They're there to kind of help you through this process and to help your patient through this process as well too, so that you're getting the most out of the data that you're accumulating.
That's awesome. So I know that we have had a lot of great information. I appreciate you sharing your personal stories
Thanks,
as
April.
well, Milay. I wonder, is there anything I didn't ask you that you would like to share with our audience?
You know, the one thing that I would share is just don't necessarily be intimidated by the genetic side of it. It is it's a new facet of optometry that we're kind of embarking on. And I think with the appropriate candidates, you just uncover a plethora of information about them that you really unfortunately can't understand with just diagnostic testing.
So Milay, for anyone who wants to get more information, how would you recommend that they learn more about AvaGen?
Oh, easy. Just like you learn more information about everything. Go to the website, call the company. They'll guide you through the whole process, April.
That's awesome. Will I see you in let's see, where are we headed next? In Boston.
Yeah, next week. Yeah, we'll be there. We'll be there, April, and I'm sure you're probably going to be there for most of the week as well.
Absolutely. Well, thank you so much for doing this, Milay, and make certain that you guys go visit Avellino and learn more about AvaGen at the Academy of Optometry in Boston. And Milay, thank you so much. I appreciate you, and I love that you're willing to share what you've learned, especially those personal stories. I appreciate you.
Thanks, April. Appreciate you having me on.